everyone. So thanks for joining today. We are here to discuss about AI, artificial intelligence, and its role in lung cancer. So we all know that it's very important for us to detect lung cancer uh, and characterize lung cancer on time so that we can treat those patients on time in earlier stage for better survival. So AI can play a major role across the lung cancer workflow, across early identification or detection, follow-up management, and course of action of the patient. So before we go to the discussion, so I'm introducing myself. I am Dheeraj Borua. I work at Medical University of South Carolina. I'm the section chief for thoracic division and vice chair for quality and safety. And I have some experience with lung cancer and AI work, and all our panelists have some experience, and we'll like to have a fruitful discussion and coming up with some ideas and what is available now in the horizon. So I'll let all the panelists introduce themselves.
So I'm Joe Azak. I'm a radiologist at Cleveland Clinic in Cleveland, Ohio. I routinely read lung screens, and I can give you our perspective on, or my perspective on our experience here.
Hello, I am Qure.ai. I am at UT Southwestern, and I'm a thoracic radiologist as well. We have two hospitals. One is more like a safety net, and the other one is more academic hospital. And so both we do lung cancer screening in both. So we do have experience of looking at different patient settings with different patient backgrounds. So I'll be talking a little bit about our experience with that. And we've had very recent integration of AI tools, so it's still like something that we look forward to explore.
Nice to join you all. My name is Vishish Mehta. I'm an interventional pulmonologist at the Comprehensive Cancer Centers of Nevada. I'm the director of IP there, and I'm also the division chair of pulmonology at Mountain View Hospital, also in Las Vegas. It's exciting to see more applications of AI, and as I see patients from screening all the way to survivorship at the other end, there's different places that AI can make a very meaningful difference. So excited to talk about this more. Thank you.
Yeah, thank you to all the panelists for joining, for giving your valuable time here. So without further delay, so I'll start with some introductory questions, and we can probably give our thoughts on those. So we know that NLSD has played a vital role in proving the benefits of qCT for at-risk populations, and that's why we do lung cancer screening in higher risk populations, the patients with smoking history for a certain period. And we know that there is a risk of lung cancer, and that screening benefits. While there have been CAD system or computer-aided detection systems in the past, how does the panel see the role of AI-powered CAD systems for targeted low-dose CTs with ever-increasing lung cancer screening volume? So we probably screen around 6 to 7% of eligible population, and we have so many ways we are thinking about increasing the screening. So how AI-powered CAD systems for targeted LDCTs will help in future? So anybody can take and give his idea or her ideas.
So I would hope that from what we started off using CAD systems, that AI is going to help us be more accurate, that is going to reliably pick up nodules that are clinically significant. So maybe nodules that are 6 millimeters or larger. We want to feel that we're being better radiologists from using AI. We want to be more efficient radiologists. So whereas I would pan through a study now maybe 2 or 3 times looking for a nodule, I want to feel more confident that the AI is going to help me pick up nodules, and I can read faster, maybe scanning through maybe 1 time or even 2 times and reading faster, being more efficient, that it's going to interact with the software that I use, that it's going to help me to make my reports faster, make them better, and maybe become a better radiologist with the AI system.
I feel that the role of AI, I mean, as everybody's saying, it is to make the work more efficient, to increase the turnaround time for the reports, and ultimately, the ultimate goal is for better patient management. In this in this whole process, we have to be careful. I think we have limited studies right now. I think we need to have more studies to get better data. We need to have more external validation in independent data sets. We also need to, look at the performance in comparison to the radiologists. If AI is not doing anything better than the radiologist, or if it is doing as better as the radiologist, still, what is it? What is the extra thing that it is providing, which would help in patient management? So I think we need to have more studies needed. In addition, to have a smooth performance of any or a robust performance of any informatics or infrastructure. A good infrastructure is needed so that integration of these images into packs, automated integration into the parscribe report happens in a very seamless fashion. Because we don't want to be like devoting extra time to do something which could be easily avoided, or which is an additional fatigue to the radiologist. So I think a lot of factors are involved in this. The ultimate goal is to make everything more efficient and better patient management. It has a definite added value given the studies that we have looked into the literature, to with some of the AI tools being really good in terms of sensitivity and specificity, but at the same time we have to make sure that we are not creating more false positive results, and resulting in more alert fatigues.
Yeah.
You know,
So
I
I
think
think those points are very nice. So yeah, I would like to know the pulmonologist perspective. Yeah.
yeah, one of the things. So I'm in Nevada, and Nevada screens 1% of eligible patients who qualify for lung cancer screening. National average is 5%. Um, and one of the things that I spend my time on doing, advocacy and so on and so forth, is trying to get patients to the scan. So I think in whether we have patients who are within the silo of their insurance payer or whether it's their employer, um, AI can really help in finding who are these eligible patients. Medical records aren't always organized very systematically, and in a given day, I am logging into at least 3 EMRs at once sometimes. So my same patient exists in different locations. If there's AI backend, it would be able to help identify who these patients are, because in some places the smoking history, for example, is written in words. In some places it's in numbers and vacuums. In some places it's preset drop downs. So if you're able to gather a list more efficiently, then a tracking software along with Nurse Navigator or reminders to PCPs and so on and so forth will make our process much more efficient. And then finally we can get those patients to expert radiologists like we have here, read those scans, and then see where they go and help them on their journey.
No, thank you so much. So those things are so relevant. You three have highlighted so many important points. And what I heard is that the CAD system that we have presently may not adding a lot of help when it is not as good as radiologists or better than radiologists. And also probably artificial intelligence in the future might help us because it may become like us, or it may be better than us, who knows. But being like an experienced fellowship trained thoracic radiologist is also helpful, because then you can implement it in the communities where you may not have an expert like ourselves who are doing only one thing and trained on one thing. So ultimately, probably if it is similar to us, probably that will also help in certain extent. And there are a lot of studies showing that AI helps, the CAD systems helps you save time in reading studies for turnaround time. But we all probably agree that in real life scenario we do not see that yet, and hopefully AI helps us in the future. And for the audience, like I have seen some questions in the chat already, so please keep sending your questions in the chat, and we will answer them after we have our discussion first, and I'll get back to them. So please put your questions out there, and thank you for doing that. So going to the second part, how does an ideal AI powered CAT system look? Like we talked about a few things. So, what are the essential features that a radiologist would want in such a system? Like, do you want something like a zero click? You just click, you get all the answers, you get a good sensitivity, or you are okay having a really high sensitivity, not so good specificity, or you want both, or do you want to classify or characterize the nodule? The diameter or volume or like your temporal follow-up? Like what do you want to see in a classic AI powered CAT system?
So I think for this, I think you're going to get a different answer from every radiologist. I think we've tried a bunch of different systems here, and I can give you sort of my perspective. Some of the systems allow where they just process the study, they spit out the answer, and you're sort of left with whatever nodules you have. And if it calls a nodule, that's what it is. You can't add to it. You can't maybe change the size of it. It'll maybe tell you the lung rads. And I think that works well if it's very accurate. But if you don't agree that there's a nodule there, or if it missed a nodule that you may have called a nodule, or if there's a nodule next to a vessel that you may have measured differently, or let's say that maybe that nodule was stable from a prior abdominal CT and it says it's new, but it really isn't new, you're not able to interact with it. So, there can be some positives to that where it processes it and it's very fast and maybe it's very accurate. But we may not be there yet in the sense that some of the systems allow you to have radiologist interaction. Well, it calls a nodule. Well, I don't think that's a nodule. You can delete it, or you can modify the size of the nodule. You can give your input to it, maybe change the lung rads. And sometimes I feel like that way works a little bit better because you're able to modify. You can say that this nodule is now stable versus the CAD said it was growing, but maybe it didn't see the prior abdominal CT. We know that the lung rads changes over time. So what we had maybe a couple years ago is slightly different that we have now. So maybe we're following nodules that are inflammatory, we would give a different lung rads to versus something we think is not infection. So I think that everybody's going to have a different opinion about what they would want. I think most radiologists are going to say, though, that they want something that's very sensitive. It's not going to miss anything that we would think may be cancerous, and that it's going to increase our efficiency. So it's going to work seamlessly with our PACS, with our dictation system. We're not just going to be finding these nodules and then having to transcribe them over, that there's some interaction and some that it seamlessly integrates with our system.
I totally agree with whatever Dr. Azok said. To me, I would rather have so based on the integration of Fleshner and lung rads, I wish there was one system rather than two, but those are the two our to fallback standard guidelines, right? So we want to make sure that we are not too sensitive about getting like 1, 2, 3 millimeter nodules, because what are you going to do with that, right? So there has to be a certain criteria beyond which, yes, it should pick up. And then the number of nodules, right? You don't want to be AI to be telling you like 20 nodules. If there are like 20 nodules in the chest CT, again, we need to kind of put a limit as to how many nodules based on the size, based on the character of the nodule. So there may be a smaller nodule, which is more speculated, than a larger nodule, which has, fat and calcification. So again, those characteristics have to be, I think, looked into. Another thing is I've seen nodules along the pleura and the diaphragm. In my personal experience, I think the AI does not measure that as accurately as it should be, because it kind of includes a little bit of more pleura and diaphragm in that. So I think that's one place where I would be, more careful when I'm, reviewing the nodule size and character. The best thing would be, to review the prior scan to make sure, you have to have a pop-up or maybe integration into the Power Scribe reports. What was the prior measurement? What is the current measurement? and sometimes even go back multiple scans, because that's what we do as real radiologists, right? In the real world, we don't just go back one scan. We go back like 6 months to 1 year, or sometimes even 2 years, based on the character of the nodule. Nodule is just not solid. We have semi-solid ground glass nodules. So all these features need to be taken into consideration, and not just, the size. So, I mean, there's a lot of work that goes into these reports.
Yeah, I think having risk predictors is very, very helpful, especially for cases where you have more than one nodule. And I can't agree more about the point about looking at nodules in the past. There's different deployments of radiology systems. If patients are able to have all their scans in one place, that's great. For example, I have a login that I use daily for one system, and that same system is being used in different physical locations under different accounts. So if a patient went to a hospital versus a clinic, I see the images in the same software, but it's patient ABC-H for hospital or ABC-C for clinic. So sometimes I have to dig under different name variation of the same name to find that same patient. So I find sometimes they've had an abdominal CT showing the nodule 5 years ago. So if it's new and if it's 2 centimeters, but it's not changed for 5 years, that's it. You're pretty much done. So being able to look, I guess, out of its scope, maybe, if that's even fair to say, would be very, very helpful. So I think deployment really matters. Volume tracking is really important um, as well. So things like this would be what I would look out for as being very, and patient reminders, physician reminders maybe um, would be terrific.
Yeah, probably that is where the AI will probably able to help with the current CAD systems we have. So what I heard is that, like, you do not want to detect all the nodules, you want to have the characteristic, and that is probably more important for us to know from the AI. And probably in the future, AI will able to help us knowing the characteristic better, like whatever we describe now, speculation or whatever we describe, or the fat or calcification in a better way than what we do. And also some kind of interactive software will be necessary till it 100% correct, as Dr. Azuk said, because you would like to change some of the measurements or delete or include nodules when you are working with the software. You do not want the software sending a report to go to the system if you do not agree with that. Till it is 100% correct, you will need an interactive software. I think those are really good discussions. So changing gears a little bit. So when it is a kind of a perfectly kind of good solution. So if we have an AI tool capable of providing consistent volumetric calculation, so you can do consistent volume measurement. So what is the clinical value to doctors in areas like calculating volume doubling time? So I'll ask from Dr. Mehta first. Like, what do you see with the benefit of volume doubling time in lung cancer workup?
Certainly. So I'll give an example. If you have a nodule that's 1 by 1 by 1, right? It's 1 centimeter cube of volume. So if the nodule increases in size, I use air quotes, and goes to 2. So 2 by 2 by 2 is about 8 centimeter cube. So if you just go by diameter and say that's double, well, the volume has gone up 8 times. It takes 25% increase in diameter, assuming this is evenly distributed, to reflect a doubling time. And that's not something that's always appreciated, at least colloquially. So being able to see upfront change in diameter X, change in volume Y, and that discordance between a small change in diameter showing a big change in volume will probably lead to earlier intervention, or considering the change as being more meaningful rather than, okay, fine, we'll give it maybe another 3 months. Perhaps the earlier intervention is what makes the difference between um, lymph nodes that are not involved versus some occult disease in the lymph nodes. It could be, I don't know, but that's some place where I think that would be perhaps a meaningful difference.
Yeah, I agree with what Dr. Mehta said. I think for me, like, when we see a nodule, let's say, give an example, there's a 10 millimeter nodule that looks suspicious on an initial scan, and then you come back for 3 months and you're looking at it. And generally, we have to say, is a nodule growing if it's maybe a millimeter and a half or so is what the guidelines state. At that point, you're sort of deciding, well, if you get it measuring, let's say, a millimeter bigger, is it really growing? And at this point, you're either going to, maybe you would do a biopsy if you thought it was growing, or you would follow them in 6 months. Well, I think at that point, sometimes we can't really tell. You may be a millimeter bigger and you don't really know what you're doing. And I think in this situation, the volumetric can be really helpful because it can either make you more confident that it is growing and maybe you want to go right to biopsy at that point or do a PET, versus you can confidently say it's stable at 3 months, let's go out to 6 months, which is what the current recommendation would be. So I think volumetric can give us added confidence and make us better radiologists for deciding how best to proceed in these situations.
Yeah, I do agree with Dr. Mehta and Dr. Zilk. And in my experience, I think 3D volumetric measurement has a huge benefit. There are times when you're measuring the nodules on the axial images and you're not looking at the sagittal and the coronal recons. They may not increase by, they may look very similar to the previous one, or they may have increased by a few millimeters. But when you go to the sagittal and coronal recons, you see that, okay, they have elongated. So it depends upon the slice thickness that you're using. It also depends upon reviewing the sagittal and the coronals to really get, the entire picture of what is happening to the nodule if it is going in a different dimension. So I think those are really good. And then again, as I said, the only, I think along the pleura and along the diaphragm is somewhere where these 3D volumetric segmentation or measurements may not be as accurate, but I think it has a huge benefit.
Mm-hmm. So what I got is that 3D volumetric is really helpful from both pulmonology and radiology side, and there are some areas where probably we may have to do some interactive way because near the vessel or diaphragm or pleura it may be difficult. So my question is that both for pulmonologists and radiologists is that how commonly we are using it or asking for it, and when we have AI kind of added CAD system which perfectly does it, are you going to use it all the time, or you will use it in some specific scenarios?
I think from my side, it would be hard to ignore, volumetric change, especially something like doubling. So even though that's not necessarily in the forefront of our consciousness while talking about it, if it's there and you can see it, then maybe that tells you, okay, fine. The next step, instead of CAT scan in 3 months, is going to be PET scan in a couple of weeks, and perhaps there will be some change in behavior that way. That's my best guess.
I think if it's built into the system, I think you click on it, it's there. It's just another piece of material that you have to make a decision, is something growing or not. And I think the AI systems coming out and becoming more seamless and automated, that it'll just help us move faster and make better decisions if something's growing or not.
I think there's a question from the audience, just because this is in the context of volumetric measurements, are we using it in our daily practice? Actually, I would like to pose this to our, my co-speakers. In my practice, we don't use it on a regular basis. We do use 2 dimensions. So that is why, I feel like I've seen the reports have not looked at radiologists. Sometimes, they, especially junior radiologists or residents, they don't look at the sagittal and the coronal dimensions. And that's where I think this can be of use. So please feel free to.
Yeah, I think that's a very good question. And we'll probably go to the audience question at the end when we are done with ours. But that's a very good question. And I can give you my kind of scenario. So I use it when I see only millimeter change, and I think it is significant. So if I cannot make myself believe that this change is not measurement error, and it's only like 5 to 6 millimeter change, then I'll do the volume measurement. And then I kind of find it that it's helpful. And then your referring provider and pulmonologist will also be comfortable that, okay, volume-wise it changed, so it's probably a real change. What do you think, Dr. Ajo?
Yeah, I agree. I mean, I think it can be helpful in this situation where you're questioning yourself. You don't know whether it's growing or not. And I think it can be helpful in those situations. It may tip you one way or the other, where you're not really sure. Especially, it can be helpful for irregular nodules, where it may look like it's stable in one dimension, but like you said, in the sagittal coronal, it may look slightly bigger, and I think it can be helpful in those situations.
Oh, thank you so much. So, changing the gears a little bit here. So, when we view those systems, when you view the CAD system or AI developed CAD systems coming, so thoughts on separate viewers with editable capabilities so for nodule detection and reporting via PACS integrated non-editable workflow. So, which one would you prefer? You want a system that is editable, separate workstation, or you want a system in packs which is non-editable? So we discussed part of it. Probably the ideal will be an editable system in the pack. So what's your thought on that?
So I think this can work different ways. I think in an ideal situation, it would be in the PACS, because you work at the PACS every day. You're used to the PACS. You know how it works. It probably would fit in better with your workflow. But a lot of the products that are being developed aren't built through the PACS, and some of the companies have much better systems that's available in the PACS. So I think in those situations, it might work better to not use the PACS. I think as like a chest radiologist myself, it's not a big deal to use one other program specifically for lung screening. As a general radiologist, though, if there's a different system for each type of AI, it may be very clunky going between all these different viewers. So I think there can be some benefits, obviously, to having a specific lung screening viewer where you're able to make changes, and that's dedicated for that. And it fits in well with your PACS. It goes to your PowerScribe. Everything works seamlessly. But again, sometimes integration with the PACS, I feel like, may be better.
This is a great question. I think at the end of the day, you want to be working fast, and you want to be doing accurate studies, right? I mean, with ever increasing volumes, I think the general input that we've got from our colleagues and radiologists or co-radiologists has been that it should be integrated with PACS. We have had a couple of AI systems, and it just adds more series to your PACS. But at the end of the day, I think if you're sitting on a PACS station and you have it available, it's great. But at the same time, I think it should be very seamless. Editable would be what I think would be great. But again, integration with PACS is something which is very, very important and should be robustly done. So we need a very strong or ground infrastructure, or like an informatics infrastructure here, a PACS system which is friendly with all these integration tools. So that has been the input at our place, but I would like to see hear other people's. Dr. Barwa, what do you have?
So yeah, so the CAD system that we were trying or using or we are looking at, so that is one thing most of my colleague will say, that we want something in the PACS and something editable, because you do not want all the information go out there. The second thing that we also would like to have is kind of the report when it generates by the CAD system goes to our dictation system by itself. So we do not have to pull all the information. So suppose for the nodule and the volumes and everything is already auto-populated in your report, and you just adding or deleting and correcting stuff. So we are not there yet. Probably adding AI to CAD system might help getting us there. So how do you view it from pulmonology side, Dr. Matt?
Yeah, I'm going to be, I guess, greedy and say that I want to see whatever you see. Meaning, when I see my patients in the office, I'm going to do that after we're done with the webinar. I have the hospital PACS system open, then the outpatient PACS system open. They don't talk to each other; they're separate. So wherever wherever the AI runs, I want to be able to show those images to my patient, not necessarily the back end or the workflow of the AI, but the images that the AI uses. So from my side, if there's a login at my end, and that's how I practice. With my laptop, I sit with the patients, I show them the pictures. and it also kind of reinforces the meaning of the discussion with the patient. So I think there's a lot of value there. If there are others, because there are many people who to interact with the nodule, the thoracic surgeon, oncologist, nurse navigator, so on and so forth. So we don't necessarily need to have the robustness to, and we don't want to or should be able to edit the report or things of that sort. But just to be able to see the pictures and maybe a light version where we see something about volumetrics, so on and so forth. If that's already in the report, perfect, job done. But we just want to be able to see whatever the radiologists are seeing. That's really what I would say.
Yeah, that makes sense. With our busy clinical practice, I would like my ordering provider to look at the images one time, because it's very easy to miss something or misinterpret something without always knowing the clinical background. So you guys have that kind of luxury to know about patients' clinical backup, and that always helps making a diagnosis. And with increasing volume, we cannot always talk to you if we do not have enough information in the ordering request or our system. So that always helps. It ultimately, the goal is to serve the patient and give a better diagnosis from our side that helps in management. So when we talk about detecting nodule and diagnosing lung cancer, whatever we do targeted lung cancer screening or incidentally, the nodules that we detect are mostly benign, and they also have similar characteristic to stage 1 or stage 2 lung cancer. Yeah, so quite similar nodule, quite similar behavior. And there are a lot of publications, and people are doing works on radiomics. So what do you think that AI role will be in radiomics based malignancy risk tools in lung cancer management? What is your experience with radiomic based tools?
So, I think this is sort of an exciting area. So I think much of what we've talked about now is just using AI to detect a nodule. And I think one of the ways that radiomics can help is in the sense that right now, once we detect a nodule, what do we do with it? So we have a nodule, and most of these nodules, the 4A, the 4B, the suspicious nodules, we actually have a multidisciplinary conference that we review these at. And we might have a 10 millimeter nodule, a 12 millimeter nodule, and the question is, well, what do we do with it? Do we send them to the bronchoscopist to biopsy it? Do we do a PET CT? Do we do a chest CT in 3 months? And a lot of times there's not a right answer, and we'll just sit there and we don't really know what the best test is, and it's not always apparent. Well, I think where radiomics can be helpful is in the future, it may be able to look at features of that nodule that we can't see as radiologists or as pulmonologists, besides the size, the density, maybe the borders, or if it's been growing or not. It would tell us maybe something more that would say, this nodule is more suspicious maybe than you think, or less suspicious, and we would be more apt to go after that nodule to biopsy it. Or it could tell us, this is most likely benign. You could follow it in 3 months or even 6 months if it doesn't say, if it thinks it's not cancer. So I think where radiomics can be helpful, and it's somewhat of a black box at this point. I think a lot of the research is exciting and very interesting, but I think if it pans out and if it works, I think it will let us better manage these larger nodules to tell us be more aggressive or less aggressive. And even for smaller nodules, so now nodules less than 6 millimeters on a baseline, we don't follow those for a year. And maybe something about a 5 millimeter nodule, radiomics would tell us, well, this is very suspicious. Maybe we would follow that in 6 months, and we would pick up some of these people that are now falling through the cracks. We would be able to pick them up earlier. So I think it has the potential to tease more out of the information that we're seeing from these nodules than we can now. But I think there's a lot of work that has to be done with it. And I think it's interesting. I think there's a lot of research that has to be done. It has to be transferable to different populations. And I think it's very challenging research, but I think it has the potential to help us in the future.
Yeah, I echo with what Dr. Azalka said. I mean, it has a great potential to looking more than what we as radiologists do on CT, and to extract features which can be used for genetic studies and somatic mutations and all that can be extracted from that. And I think there have been great studies which have shown very good and fruitful results. I think the one step, I think the one shortcoming is the extraction, the feature extraction step is quite cumbersome, and it is not that easy. It's not like you do it at the click of a button. So that is something that there's an obstacle there, and it can be also influenced by the parameters that you have. Like various machines have different acquisition parameters, and the reconstruction parameters may be slightly different. So it all depends on that, and a lot. So that may potentially affect the results. So I think there should be more studies done, and to be able to apply it to a more to generalize it to a bigger population, and also standardize those features.
I would agree. I think it's going to be interesting to see where this goes. One of the things that may be helpful, perhaps, is if images are being done on different machines with different protocols. Say you found a nodule on an abdominal CT, but the protocol for PECT is different number of slices. Combined with AI, perhaps we could have a smoothing out of the data where there's kind of the same information, the same DICOM data perhaps is balanced out over different acquisition modes and gives us more reliable results that can be compared across different modalities. Perhaps that's somewhere this goes. That would be very helpful.
Yeah, I think nicely said. I think we all agree that radiomics will probably help, and we are not using it in currently because of the process. It's really cumbersome when we try to use it. And AI, as you said, Dr. Mehta, will probably in the future put everything together and help us kind of evaluate those radiomic features in from any type of scanner, any type of reconstruction with similar results. And if AI and radiomics grows together, that will be something probably we'll see in the future. Uh, so but we do management of lung cancer or detection of lung cancer is a cross department effort. And Dr. Mehta, you mentioned about some roles like when we how AI can play a role in managing nodules from incidental settings and ensuring that a potential patient doesn't fall through the cracks, ensuring that a follow-up happens, and whatever suggestion we had suggested, like a patient gets that, like we suggest a 3 months follow-up or a PET CT or a biopsy, uh, that how AI can help us managing that, like from detection to ensuring that the follow-up happens.
I think focus on something like this is going to be as meaningful as finding the nodule in the first place. So if your patient doesn't come back to get their PET scan, and if they don't have um, their biopsy or whatever else is needed, then it wasn't very helpful to find this in the first place. So I think it will help in reducing human error at the level of, say, maybe the organization that needs to make a referral, or even at the patient for forgetting. Say your patient needs, and this happened with me. I had a patient who needed a follow-up scan, and between when I last saw him and that scan, he ended up in the hospital who had an MI, completely unrelated. He forgot, lost a follow-up, so on and so forth. Reminders, which I try and set calendar reminders a few months out, something like that help, but that's also very cumbersome. Across departments, it would help a nurse navigator, for example, or lung nodule program coordinator to track and send reminders. Maybe it will prioritize the reminders. Hey, if patient is got a nodule over 10 millimeters and they need to be followed up, that goes to the top of the queue over somebody who has maybe 7 millimeters and can be seen a little bit later, so on and so forth. So that's one of the important places where a nodule program, whether incidental or screen detected, will need help. And that's going to be as critical as finding the nodules in the first place.
I think I agree totally with Dr. Mehta. I mean, there's a huge potential for AI to, to work in parallel, to, be able to, again, set alerts, get the prior images. Maybe there were images done in a different hospital, somehow try to make it easier for the radiologist, right? So the ultimate aim is to basically, help out. the radiologist and to be more efficient. So I think it can do a great job if in that realm.
Yeah, I agree. We've had a lot of patients where incidental findings have been missed. So we at the bottom of each of our CTs, we actually have a macro that we can add that the radiologist clicks, and then it clicks an organ system, and we can denote whether there's a thyroid nodule, a lung nodule, a renal lesion that needs follow-up. And then when that gets sent to the EMR, it gets flagged. There's a message that's sent to a team that sort of manages these incidental findings. But I think AI can be applied to scan the record to make sure that those patients get the appropriate follow-up they need, and that if the radiologist doesn't use the macro, that they can actually use the processing to basically scan reports where something is recommended, and then they can try to see if patients got appropriate follow-up. So I think there's a lot of uses in AI that could help these patients.
Thank you so much. So one question that I have is that we are training our young radiologists to become good radiologists. So, and when we implement something like a CAD-RAD system that detects the lung nodule for us, is it going to affect the training for the radiologists? Like they will just rely on the CAD-RAD and they will kind of not see nodules and not train like us, like who can find nodules from a regular CT?
I don't think that is going to be 100% true. I think it also depends on like how the education, right, the teaching, and then also like what you stress on when your kind of new residents are coming in. I mean, I think you can kind of format their curriculum in a fashion where you kind of kind of stress on that this is the AI is not going to be 100% accurate, and they need to be, I think it all is based on how you are, structuring your education to them.
Yeah, I agree. I think it's just will be different. I think the training will be just different. I know from like when we started off, like I think there's less of a reliance on us to use chest radiographs versus chest CTs. The older generation of radiologists relied on chest x-rays for everything, and the younger radiologists want to just jump to a CT. So I think, or in the past, I think chest x-ray training was probably better 30 or 40 years ago versus what we had. I think we'll just stress different things, and I think the younger radiologists will be trained differently, but I think they will still be, excellent radiologists in being able to pick up things.
Well, that's interesting. Not being a radiologist, maybe just how AI needs a data set to train on. Maybe part of radiology education is modules of scans without any AI. I mean, it's kind of crazy to even say that you'd have like a non-AI rotation or something. I don't know, not a radiologist, but there is something to be said for that. There is an example from bronchoscopy. The way we are able to do bronchoscopy has changed. So I was maybe one of the last fellows who did in my interventional fellowship navigation and robotic assisted. Now it's all robotic assisted. So what do you do if the machine does not start that day, or something like that happens? Then once in a while something will happen. Nothing is perfect. I don't know, but I think that's a great question, and should be seriously looked.
Yeah. I think
go ahead.
Sorry. No, I think this is a great point that Dr. Barber you've put in you've placed, because I feel that this again stresses the importance of education. To be able to educate them correctly, like not totally rely and depend on AI, and that's why we need more studies to validate, and also at the same time, you have to kind of always keep in mind that you cannot be entirely dependent on a machine. Although AI is great, is awesome.
Yeah, I think those points are really good. So the thing I'd like to say that if the AI is 100% accurate, then why need to know how to look for nodules? Yeah, so you have AI. Like I will give you an example. Like when I started looking at CT scan, I could diagnose vertebral collapse looking at the axial scans. So I can say there is a vertebral collapse looking at the axial scans. But we do not do that anymore because we have the sagittal. We just get it. So we can look at the sagittal and we can say vertebral collapse. So why do you need to learn to diagnose vertebral collapse on an axial scan? So some of the stuffs may not be necessary if AI aided CAT systems becomes 100% correct and accurate. Okay, so last question from our side will be the future of lung cancer detection. So will AI be a backup reader for every scan, reading at a minimal cost per scan? What is the potential of multimodal risk calculators combining radiomics and liquid biomarkers aiding AI? So what do you think? Your thoughts?
So I think in the near term, I think it's practical to think that there will be some AI system that eventually will look for nodules in everybody. You know, in the future, it's possible that they may scan every body system, so liver, kidneys, pancreas, looking for masses everywhere. I think that's probably realistic in the sense that maybe in 10, 20 years, you'll have something, at least for nodules, that would be looking for that. I think it could, go to different organ systems, like I said. The question of proteomics and liquid biomarkers, I think, is difficult to know. Liquid biomarkers may in the future be a screening tool for cancer for all sorts of different patients if it becomes, more practical. It's hard to know how radiomics is going to really fit into this, though. It may work in the sense that it can be used for specific things like nodules, maybe to monitor how lung cancer is being treated, but it's hard to know how radiomics would play into like scanning a patient overall for things.
Yeah, I think that's a very interesting thought. One of the things I think of is, should we say, okay, in every 100 low-dose CT scans, what's the negative predictive value of a biomarker? So if I have 100 scans with nodules for screening, can I use the biomarker to put those patients one or the other side of risk? You can flip it around. Say patients go through primary care practice. Anybody who qualifies for low-dose CT gets biomarker added onto their routine blood work, and anyone's biomarker is higher, then okay, those are the people that need to go and get um, scans for sure. Or even if currently you're supposed to screen patients who've quit within 15 years, if they have maybe 15 to 20 years history of smoking, the risk is a little bit higher. Those patients get the CT if the biomarker comes back. I mean, I don't know. I think you can put whichever one in front of the other, and I'm sure there's going to be some benefit. At some level, if you think of the biomarker, at least in my mind, it's kind of like a PET scan, which gives some sense of the activity levels, quote unquote. So that plus AI risk score would probably be able to select cancer out much more efficiently than either one of them alone, is my assumption.
I think personalized medicine is the future, where every person has based on these biomarkers, their CT scan results. I think everything is integrated, and the treatment would be probably focused on what your results have been. So I think in some fields the personalized medicine has already started and is doing great. So I think that is true.
Yes, those are great thoughts. So I agree with you guys. I have nothing more to add into that discussion. So I'll go to the question in chat and we'll try to answer all the questions. And so the first question is AI helping from the angle of population health management as lung cancer is deadly? So do you think AI is helping in the angle of population health management?
I think that's probably one of the biggest roles it can play, is in identifying patients. Who's to say if your AI integrates with your EMR, you have a patient going through lung cancer therapy, and the AI helps flag patients with neutropenia, low white cell count, or treatment effects from their cancer. AI helps flag patients early with drug-induced or radiation-induced pneumonitis. So even though the cancer has been detected and treated at a population level, we can certainly prioritize um, resources if that's indeed necessary to go wherever the greater need is, and AI helps in a large volume, large volume setting. Yeah, I think so.
Mhm.
Yeah, I mean the from the the trials, the NLST trial, the incidence of lung cancer was not that high, right? 3%, around 2.3%. So I mean, but again, these are deadly cancers, and if detected at an early stage, they can be really, improve the prognosis of the patient. So and then about in that trial, about I think 8.9% of the lung cancers were missed on the initial CT. So, and any life save is good, even if it's from a huge population.
I think Dr. Mehta alluded to this earlier, but I think one of the big things that the negatives, or at least from screening, is we're only screening a small fraction of patients that really qualify for screening. So if AI could be applied to the electronic medical record to identify patients that would qualify for lung screening, and we could double the amount of people we're screening, we would pick up a lot more cancer patients. So from a population management standpoint, we would be picking up a lot more early stage cancers. And I think that could where AI could really help here.
Mhm. Thank you so much. So I have a few other questions that we already discussed. So one interesting question here is that can you pick up lung cancer from X-ray itself? So I'll put it in a way that goes to our discussion. So do you guys think that AI can help detecting lung cancer from chest X-ray in the future?
I mean, AI has a great role. I think there have been studies which have identified that AI does some, almost as equal or even better than radiologists in detecting lung nodules. But again, the incidence of cancer in these is very low. But overall benefit is there. Um, but ultimately, it all depends on like how the follow-up study is ordered, right? If the person is anyways getting a chest CT that will detect a nodule within a short period of time, then it doesn't matter. But in case if it's he's not, they didn't order a chest CT and AI detected it, then it has a definite role. So although the incidence is very low, but still one life saved is important.
Yeah, I think AI has some benefit in helping maybe radiologists pick up nodules. I would say that the NLST, it showed like a 20% reduction in mortality from lung cancer from screening versus chest X-ray itself. So there may be some benefit, but it's probably not going to be as good as CT. And while chest X-rays is probably better than nothing, I would think that maybe AI could help marginally, maybe with radiologists. It's not probably going to be as good as CT.
Yeah, I think in terms of tracking large number of patients, if you have patients where they're getting X-rays for incidental reasons, sure, flagging incidental X-rays, yeah. But I don't think we can. I agree with the others that screening is CT. But for incidentals, yeah, I think there's some value.
Mhm. Yeah, I think I agree with those comments. So we discussed about availability, FDA-approved systems, and we discussed about having them together with PACS and as a different software. So we already discussed those stuff. Um, so somebody asked about the lung nodule detected on a CT scan of the heart, neck, or abdomen. So you have guideline on incidentally detected nodules on your Flessner guidelines. You do not have to always do a regular CT to follow them, and they are followed similarly the way you detect a nodule in chest CT. So we can refer that to Flessner guideline, and that's not the part of today's discussion. So I'll skip to another question. we discussed about volumetric measurements. So here is a question. So do you use dedicated hanging protocols on packs to incorporate the AI output?
We don't use any dedicated hanging protocols. Everybody has the choice to do them. I mean, but yeah, it's up to them. But we do have the series at the end of the the entire series. We have the AI images towards the end, so everybody knows that is there. But yeah, we don't have dedicated hanging protocols. But I'm sure that people have different view.
Yeah, we don't use any different protocol to incorporate any AI output. The screening software we do use will create a picture of the nodules that we sort of annotate, and we'll send them to the PAC. So the patient can see them, the ordering physician can see them, and it does go into the electronic medical record. But we don't have a specific hanging protocol per se.
We neither have any hanging protocol, but the question here is that another important question comes is that do you let the AI send those images to the PAC system before you confirm it, or you confirm it and then let it come to the PAC system?
Ours, we confirm it and then we send it. So nothing gets sent until we sort of approve of it. So we will annotate the output of it, and we'll change it if it's incorrect when it sends it or when it processes it initially. So we always agree with it generally, and then if we send it and we sort of made an error, we can resend an updated version of it, and then the report will also get generated as well, the radiology report.
Yeah, we cannot edit it. We don't have the capacity to do that.
Yeah, so that is where we probably stand everywhere. So some centers, they have some kind of interactive software where they can change and they can send it. And most of the centers, they do not have that. Most of the time, it is the vendor's software in the cloud, probably processing it, sending it to your PACs. And that is what we had trouble with. So we tried with one vendor, and some of our radiologists, they didn't like it because sometimes you do not want to include an image that you do not agree. So that goes back to the same discussion that an interactive software is something that we all will like in the future, unless it's 100% accurate, and that's probably not in the near future. So another question is, we probably discussed about this incidental finding. How do you manage incidental finding in your practice? We discussed about AI, the role of AI for managing incidental finding. So this is a good question. I think having a perspective how we are managing currently will help us get some idea how AI can help in the future.
So I sort of alluded this before. So if we detect an incidental finding, we have a macro that's built in that will flag it, and then it will get sent to different groups. So the people that manage nodules, thyroid. So we have sort of each organ system sort of has its own thing, and we can click on what study to order. So patients will get sent to the appropriate group. We have physician's assistants and nurse practitioners that meet with each of our screening patients prior to the screen to make the sort of informed decision. So they will go over any findings that we see. So a common thing we see is coronary artery calcification. So if we actually see moderate or severe, a lot of these patients will actually get sent to a cardiologist, or at least have a discussion of get sent to a cardiologist. So we try to, there's a lot of incidental findings we see very commonly. So these patients commonly will get shunted to different providers to make sure they get those managed.
We have something very similar, as Dr. Azok said. The nurse navigator, she goes over with these findings, and they will refer the patients to the appropriate physician or department. But we also use the ACR, incidental findings paper. We have integrated those recommendations in our PowerScribe reports to macros, so we use them a lot.
Yeah.
Recommendations go into those reports.
Yeah, I have a couple of different experiences, depending on where the scan is done. So, for example, if the scan is done at my hospital, we do have a nurse navigator, and the thoracic surgeons are, of course, part of the conversation for nodules. And if they find an aneurysm or something like that, then they get notified. Patient goes sees them. If my patient scan is done outside of the hospital at independent diagnostic centers, then nothing is happening necessarily unless the PCP sees it and does something, or if I'm the one ordering the scan, when the patients come see me, I print the scan, and if it says thyroid nodule, I underline, and typically will order an ultrasound and make a referral as well. If it's coronary atherosclerosis, almost all these patients, it's the same population who have heart disease. They usually have a cardiologist underlined mechanically on the printed paper, hand it to them, or enter the referral myself, and they leave with a referral again in hand. So I try and make it mechanical, and I think that helps a little bit, increasing some of the follow up. And also, outside of the hospital setting, we don't have any other option because they could get their screening CTs 3 different years in 3 different organizations.
So yeah, I think in US, all the places like Cleveland Clinic or UT Southwestern, they have really structured way to do it, and we are trying to implement something here at MUSC, and we are not quite successful doing that. And there are so many incidental finding. We looked at the current like last 1 year. Report of incidental finding. There are thousands of incidental finding on all our studies, so we probably need some kind of AI or interactive tool that will help more than one personnel managing that. So there are way more findings, and probably out there, AI will certainly probably help. Okay, so we have the last question here. Since the human performance is around 80%, I hope I'm 80% correct all the time. Is it fair to ask for 100% accuracy from AI? And I think that is what we are asking. So, what do you guys think? Is fair to ask AI for 100% accuracy?
I don't know. This question is a little tricky. I mean, are we asking AI to be 100% accurate? Well, let's.
Yes.
Well, then we need to have studies. We need to have validation studies. We need to have a lot of studies to prove that. It seems like you know, it seems to be like, to me, AI can help us being a support tool rather than being more accurate. Well, we still have to look into that, right? In the study so far, there has been no study which, at least to my knowledge, that was like AI was 100% accurate. But in future, because there's AI algorithms, they have they do iteration, right? They continuously are improving on themselves. So this is something that needs to be seen.
I guess if the AI technology says it's 100% accurate, then it should be. It is. You can say we should be fair in advertising. If I say my yield doing procedures is X, well, then it should be X. I don't think any system is perfect. I don't think it's possible for anything to be perfect. Also, what you compare as the gold standard when you say 100% accurate. So I think I understand the question of where it's going, but I don't think we know enough to even be able to answer that question. For me, I don't see this necessarily as being closing the gap between 99 to 100% success, but in bringing healthcare from, say, if you're functioning overall at 80% good, to having the lowest level, or the least good performer, so to speak, be elevated much closer to the mean. That's how I interpret this at this time.
I think all you could help is that if you say the average radiologist is 80%, that the AI would elevate that to make it substantially better. So I don't know what the correct number would be, but I think if you're missing one case out of 1,000, you would miss half a case out of 1,000 or less. It would make you better. And I don't know what the correct percentage is, and I think it's going to be impossible to quantitate that. But I think just whatever we use for AI, it'll make us better in the future, better able to manage patients, missing less nodules, getting better care for patients, doing less invasive studies, but still providing better care. So.
Mhm. There's a very nice comment here from Guy, and he said that AI technology could eventually serve as high quality digital consultants to resource deprived regions of the world that wouldn't otherwise have access to a radiologist's expertise. I agree with that. So, if we have a technique that can go through the lung and detect a nodule where there is no radiologist, but they can do a CT scan, why not use it? Yeah. So, any comments on that?
I don't know. Maybe AI plus the primary care is better than no radiologists at all. I guess that's maybe one way to look at that. I mean, there's of course legal ramifications to practicing outside scope, technical, and I think that's worth considering. But that's one way I think maybe this could help improving access.
I mean, this is a great comment. I think this is AI definitely has. I think it has a huge potential there, where you have shortage of radiologists in countries, where there's like ever increasing volumes, and you don't want to be like, if AI has shown great performance, then it can definitely have a role in uh, you know expediting the care of the patient, or for things like lung cancer, or even for other um, life-threatening conditions.
Yeah, I think there is another question. Is are there any areas where we are currently not using in lung cancer detection, not using AI in lung cancer detection? I I do not know that we all are using AI in lung cancer detection. Some of the CAT system that we are using are not at that level to say that those are AI CAT system. Uh, so I do not think we are universally using AI system for lung cancer detection. Do you all agree?
In some places, I don't think they have a specialized software to do lung screening. So some places are just going to have the radiologist. So, in the future that may be common, but I think a lot of places don't use any type of AI.
I uh, so we already discussed about AI finding X-rays. So then there was another question on chest X-ray and AI. Before I do not see any more questions out here. Uh, Before closing, you guys have any final comments?
Thank you for giving us this opportunity to discuss. This is a hot topic, and I think AI has a huge role, a potential role in ultimately patient management, good patient clinical care, and also be a support to the radiologists. Thank you.
Thank you for having me. It was great learning from you all and being a participant in this.
Yeah, and thanks to you for having me. I think AI has a important role to play in detecting nodules and helping us manage nodules better in the future. So I think it's an exciting time to be a radiologist. So.
Yeah, no, thank you all, and thank you, the panelists, for your valuable time and all the remarks that you put through from your experience and using AI. And we hope that AI will be a future tool that we'll be using for detection and management of lung cancer, from detection to kind of treatment and further follow up. So we conclude here, and thank you everybody for joining and putting your questions in the chat. And we had a lively discussion. Thank you, Qure.ai, for arranging this. And for all the people who have joined, if you have any further questions, you can reach out to Qure.ai, and they can forward the questions to us, and we'll try to answer them if there is any. Thank you all.